Thank you, Bernie, and thank you everybody for having me here. When I retired in the spring of 2010, I didn't think I would be back 4 years later talking about lung cancer, but stuff happens in life, and it's a real honor to be here and to be able to raise awareness about this critical issue. So thank you, Bernie, for that introduction. So I will say I'm also back at school getting my master's in public health to better allow me to be an advocate, and that's at UConn. I was there last year as a non-degree student because I missed the deadline. So I've got 4 classes under the belt, got accepted, so here I am. And I'm also working part-time as a consultant to the Leahy Hospital and Medical Center, helping them with their lung cancer screening research projects. It's a pretty long commute, 2.5 hours each way, and the traffic is pretty bad. But I go up there about once a week now. During the summer, it was a couple of times a week before I was in school. But Leahy Hospital and Medical Center, they're my heroes. And they started a free lung cancer screening program. I'm going to talk lung cancer screening here in a minute, in January of 2012. And they will screen anybody for free. So they're amazing. And I wasn't really looking for a job, and I'm not doing it for the money. But when I connected with them and they asked me, I couldn't say no. All right, so why don't we go ahead and get started. So I'm going to talk about, in true Pratt & Whitney tradition, I will tell you that I've got way too many slides. So I'll say that up front. So I'm going to tell you about Dan's story. We'll talk some about lung cancer statistics, talk a little about what lung cancer is, the risk factors, sort of natural history and treatment, and then we'll talk about lung cancer screening. This is the most important part. And then we'll get into the tobacco control piece and talk a little bit more about other things that tobacco affects from the standpoint of disease. And we'll summarize. Okay, so Dan's story. How many of you here knew Dan? Okay, so there's a few of you. So after I retired the end of April in 2010. For the first year and a half, we basically, did all the retirement stuff. We did a little bit of traveling, not a whole lot, but just sort of relaxed. And then in October of 2011, well, let's back up a little. In September of 2011, Dan started to have a pain in his side. I was going to Spain to visit my dad because I hadn't seen him for a while, and Dan wasn't going to come because he had other some comorbid conditions. He had type 2 diabetes, and he had some issues with his eyesight, so he didn't really want to come on the trip. But I said, well, I'm not going until you go to the doctor and figure out what it is. He said, oh, I remember now. I was in the supermarket, Stop and Shop, helping the lady. She asked me to get a pot pie from a top shelf somewhere in the freezer. So he went and stretched. He said, I just stretched my muscle. I'm like, okay. So I go to Spain. I come back. Well, it hadn't gotten any better. So this was towards the end of September. And we went to see our doctor. We have the same primary care physician. And the doc said, well, I think it's your gallbladder, so I want you to get an ultrasound, but let's just get a chest x-ray just in case it's, you broke your rib or something. So we go home. A couple of hours later, we get that phone call you never want to get. So long story short, the end of October 2011, Dan was diagnosed with stage 4 lung cancer, adenocarcinoma. He had metastases throughout his lungs. He basically had 2 big tumors, one up here and one down here, and his right 7th rib, and that's what had been hurting him, and that's the symptom, which is typically what happens with lung cancer, is there aren't many symptoms. So by the time he was diagnosed, there wasn't much of a shot for him. So anyway, the next year and a half basically was all about, doing the engineer thing, doing a deep dive, finding out all the data, reading about all the clinical trials. Basically, we did almost everything. We did expert consults with 2 of the top lung cancer specialists in the world, one at Dana-Farber and one at Yale. We did clinical trials. We pursued investigational new drugs, all sorts of stuff. But unfortunately, as is the case, when you have a late-stage diagnosis, it was too late. And so Dan passed away on April 13th last year. Excuse me, April 12th, 2013. It's a good sign that I don't know the exact date, right, Jane? So anyway, so I decided during that journey with Dan, I got pretty involved in going deep. We had a great oncologist. He was able to partner with us. I would go do all the research because he didn't have time for it. And so I'd come and say, okay, Dr. Election, how about we try this, we try that? And he'd go take a look at it and say, oh yeah, that's a good idea or not. He was wonderful. I mean, he did stuff that he didn't know how to do, and we figured it out together. But 2 months before Dan died, I wrote this very long, impassioned email to him, poor guy, about how we needed to change things about lung cancer, and we needed to do two things. We needed to find it earlier, and I was aware that there was this lung cancer screening test that I'm going to talk about, and we needed to help patients, empower patients, and give them information so that more people could get different kinds of treatment. So he said, okay, I'll put you in touch with someone. Well, it took forever, so I wasn't waiting for that. 4 days after Dan died, I called our primary care physician. I said, okay, doc, I want to come brief all your, because he was the chief medical officer of his practice. I said, I want to come brief all your guys on lung cancer screening, and then I want you to start talking to people about it. He told me all the reasons why we couldn't do that, and I told him all the reasons why we had to do that. All of a sudden, he just totally changed his mind, and he said, Andrea, you're right. We're going to do this. He called me back a week later, and he said, Andrea, one of the things I realized when I was talking to you was by not talking to my patients about this, I was making the decision for them. So anyway, so that's Dan's story. Okay, lung cancer is the second leading cause of death in the United States. The first leading cause is cardiovascular disease. A lot of people don't know it is the leading cause of cancer deaths in both men and women. A lot of people think breast cancer kills more women, but actually lung cancer kills twice as many women as breast cancer. 160,000 die each year. The 5-year survival rate is 16.8%. That's pretty much unchanged since 1975. It is the most common cancer in the world, 1.6 million deaths in 2012 worldwide. So if you just compare it to a few other things, I got some quick statistics slides. AIDS, 17,000, breast cancer, 40,000, and we already know lung cancer at 160,000. And this is just showing you the relative rank of all the different cancer deaths from a percentage standpoint in both men and women. And you can see at the top of the list is lung and bronchus for both men and for women. And you can also see the next one down, it's a significant difference. You go from 28% for lung and bronchus to 10% for prostate. Similar kind of thing. Lung cancer is almost double breast cancer, the next one down for women. What's the risk? 1 in 13 if you're a man, lifetime risk of getting lung cancer, 1 in 16 for women. If you take a look at who gets diagnosed, less than 40% of diagnoses every year are in people who currently smoke. There's about 224,000 diagnosed every year. Of those, about 50% used to smoke, former smokers, and there's about 10 to 15%. It's getting to be a little bit more every year, about 15%, I would say, of people who have never smoked. And the second leading cause is radon, and we'll talk a little bit more about that. This just shows the trends. We're engineers. In many cases, we like data. So if you take a look at lung and bronchus, that peak that you see right there coincides with when men started to smoke heavy duty in World War I. In World War I, they came out with a cigarette rolling machine. It became a little bit easier to make cigarettes, cheaper, and the tobacco companies provided kits for the soldiers in their little packs. They got chocolate and they got cigarette rolling machines and tobacco. That's now turned around. There's been a significant effort at tobacco control and smoking cessation, and so the rates are coming down. If you take a look at women, they're just starting to turn around right here, because women didn't start smoking until World War II. Rosie the Riveter, she had a pack of cigarettes right on her arm, and women were not as quick to stop smoking. If you remember the Virginia Slims ads in the 1980s, they encouraged women to smoke. And this just shows that from the standpoint of lung cancer in women, if you take all the other female cancers combined, lung cancer kills more than those. 5-year survival. This is a great chart because it shows all the different kinds of cancers and what happened. Almost all of them have increased survival, 5-year survival rates. If you take a look at lung and bronchus, 12, 13, 18, not very impressive. The main reason for that is because we don't find it early enough to be able to cure it, but that's going to change. This just takes a look at globally, and what that shows is the blue is the incidence, how many new cases you get of lung cancer every year worldwide by region. The red is the mortality. You can see that the lines are almost exactly the same because if you take a look at mortality to incidence rates, it's 0.87%, once again showing the poor survival. The emerging 58% of new cases are in underdeveloped regions, so these are the parts of the world where people are still smoking. There's also pollution in China. And in China, a lot of people started smoking, especially males, about 25 years ago. So their lung cancer rates are actually increasing at this point. These numbers in Africa are probably a problem with reporting and just data. I don't think they're really that low. In general, worldwide, the incidence for men is coming down. For lung cancer, the incidence for women is going up, except in North America where we've turned the corner. So what is lung cancer? It's a non-infectious chronic disease. What does that mean? What that means is it's not contagious, so you can't catch it for someone else. What chronic means is it takes a long time to develop. Basically, what cancer is just you get damage in the DNA of your cells, and so the mechanisms for controlling cell growth are damaged and can't take over anymore. It typically takes hundreds of thousands of mutations to your DNA to cause cancer, and that includes lung cancer, so it takes many years of exposure to a carcinogen. Most cancers arise in the cells that are duplicating in the body. So in epithelial cells, which are both your glandular cells and the linings of your skin or the inner linings. So in the lungs, the cancer arises in the epithelial linings in your lungs, in the bronchi, the bronchioli, and the alveoli. The really bad thing is that today smokers are actually more likely to develop lung cancer than smokers 50 years ago. And the reason for that is because the tobacco companies have spent billions of dollars putting additives and changing their delivery methods in their cigarettes to make them even more carcinogen and to even make them more addictive. So it's almost, you can't get away from it. What's the histology of lung cancer? If you have lung cancer, the majority are non-small cell lung cancer, and the majority of those are adenocarcinoma. This is just an info slide for you all if you... Okay, now there's going to be a quiz at the end on this flow chart. Over 80% of lung cancers are caused by tobacco, and basically it's just the exposure to all the carcinogens in the smoke that drive the mutations in the DNA that end up causing lung cancer. And if anybody's really interested, we can talk offline about this one. So what other risk factors are there for lung cancer? Secondhand exposure to smoke. There's about 42,000 deaths in the US due to secondhand smoke exposure. Radon, there's about 25,000 in the US due to radon. Do you all know what radon is? Yeah. And also just in the soil, not only in the water, but also in the air. In Connecticut, I know when we bought our house, you have to have a radon test to check radon levels. Now, if you haven't had that and you haven't checked your houses, I would definitely suggest you go to Home Depot. They have the little kit. You can put the little vials in your basement and send them into the lab. And then if you have a well, you might want to check your water as well. But there's a lot of radon in the United States. And there's a lot in Connecticut especially. There's some areas, I know in our street, there's a couple of houses that actually have radon remediation systems. I have a brochure over there on radon. If you had some other type of smoking-related cancer, and I'm going to go over which ones those are, but for example, bladder cancer is smoking-related, then it increases your risk for lung cancer. If you have a family history, so Dan's sister died of lung cancer at age 62. Both of them had been quit for about 10, 11 years before they were diagnosed. There is a dose-response relationship with smoking and lung cancer, so the more you've smoked, the more likely you are to get lung cancer. And there's environmental pollutants. Pollution, worldwide, there's 225,000 deaths due to pollution, dust, asbestos. And then if you have COPD or pulmonary fibrosis, you're more likely to get lung cancer as well. Most COPD cases are brought on by smoking as well, so it's a dual whammy from that standpoint. The natural history of lung cancer. So what happens? I'm going to take you through using Dan's thing. So you have DNA damage to cells, and it accumulates with age. So the average age of diagnosis for lung cancer is age 70. And that's because it takes a while for the damage to come in as you smoke. Obviously, the more you smoke, the quicker the damage can come. But if you're like a pack-a-day smoker for 30 years, then that's how you're building up that. So results in abnormal cell growth. You get a lesion, which is just another word for a tumor. Pathological evidence means that if they look, they can actually find that you have cancer before you have symptoms. And there's very few symptoms in the early stage, and I'm going to show you what those are in the early stages. So if there's no screening and there's no symptoms, then you don't find out until you get symptoms. By the time you have symptoms, the lung cancer has spread, and the chances of a cure are pretty small. So diagnosis, if it's advanced enough, you can generally see it on an X-ray. Otherwise, you would have to do a CAT scan, and then once they see something, then you go in and do a PET scan, which is essentially they inject a radioactive glucose into your system, and cancer eats it up and starts glowing. And so when you take a look at it on an X-ray kind of image, you can see where the cancers are. Biopsies, magnetic resonance imaging, typically they use that for the brain. Lung cancer tends to spread to the bones, the liver, and the brain. Those are three common areas. About 50% of people who have lung cancer have it spread to their brains. Luckily, Dan didn't have it spread to his brains. That's a bad way to go. And then we'll talk a little bit more about treatment. Early stage, you can go for a cure with surgery. And late stages is basically systematic and chemotherapy, radiation. And there's also some new treatments out nowadays that we'll talk about on another slide. And then we've already talked that 5-year survival is pretty low. It's 16.8%. If it's localized, the data shows 54%, but we've got data now that shows if you have a screen-detected lung cancer, 5-year survivals can be up to 90%. So that's pretty exciting. Okay, so how do we treat it? We talked about surgical. If you find it when there's just one small pulmonary nodule, you can go in minimally invasively even and take that out. So the earlier you find it, a lot of people have told me when I've talked to them about this, well, I don't want to know. And that's because it's such a horrible, it's almost like they say, it's a death sentence to find out you have lung cancer. I don't want to know about it. Well, that's okay, but it's going to happen regardless. So at this point, what I'd like to do is tell people that there's hope because there is a screening test. We'll talk in more details. And if you find it early, the surgery is not that bad. And you go in, you take a little piece out, and depending on how big the tumor is, where you find it, when you find it, there's different options from the standpoint of how much of your lung they take out. They can now just take a wedge out as well. So they don't have to, in the old days, they used to have to take one whole lung. They don't have to do that anymore. And sometimes if you do get surgery, you can either have chemo or radiation before or after just to kill any circulating tumor cells that might be out there to prevent a reoccurrence. When you're at a late stage, then basically you don't do surgery because you can't get it all, and they've actually found worse outcomes if you do surgery. So what you're looking at is a systematic treatment, something that basically addresses everything in the body. So chemotherapy, which goes everywhere. Radiation tends to be localized right at the site. And just recently, in the last, I would say, 10, 15 years, what they found is that they found that there are genetic mutations in the tumor itself that can be, there are certain pathways for how the cancer grows. And so if they target those with a molecular treatment, they can actually stop the growth, and in some cases actually shrink the cancer. Dan's sister, who died in 2001, actually was part of the original trial for the very first molecular targeted therapy called Iressa. And it didn't work for her because she didn't have that genetic mutation, and they didn't know about that at the time. It was through these trials that they actually found that, hey, you know, this drug works really, really well for a subset of the people in the clinical trial. Why is that? And so they went in and they found out that these people had a specific genetic mutation that made them, you know, that particular medicine targeted. We now find that about 67% of non-small cell lung cancers, which if you remember was the biggest piece of the pie, over 80% are non-small cell lung cancer. So 67% of them have an identified genetic mutation. Once you identify the genetic mutation, then you basically develop a drug to target it. So there's drugs developed for quite a few of those, not all of those. And in some cases, what we're finding is that those genetic mutations are common to other cancers. So for example, the BRAF genetic mutation is common to breast cancer. So drugs that have been developed for breast cancer that target that mutation are now able to be used for lung cancer. So at some point, some people say at some point it's not going to be, now all cancer is defined by the site of origination, and that's how they predicate what they treat. But what's going to happen in the future is that it's really going to be what genetic mutation do you have and not the site initiation. And then the most recent and some of the really exciting thing is immunotherapy. There's several drugs now that are on a fast track with the FDA for approval, where what these drugs do is they actually get your body's immune system to recognize the cancer. Because the reason that the cancer grows is because the body says, oh, it's my own tissue. It's my own stuff. You know, I'm not going to kill my own stuff. So if you can get the body to recognize that the cancer is bad and it's a foreign body, then the body's immune system will fight. And the body's immune system is better than any drug out there. It works really well. The bad thing about some of these molecular treatments, and even with immunotherapies, eventually not so much the immunotherapy, but the molecular treatments is the cancer finds a way to mutate around the path of the drug. So at that point, these treatments don't work forever. In some cases, they work for some months. In some cases, they work for years. But what people are doing now is they're developing second and third generation targeted treatments that actually attack the mutation that happens that develops the resistance. So if anybody's interested, I can talk at length about that. All right, so these are the symptoms that you have for lung cancer. And you can take a look at some of those. Blood when you cough or spit. I mean, obviously, you can go to the doctor if you have that one, right? But that doesn't happen all the time. Recurring respiratory infections. You know, how often do we get a cold and it stays? But you know, you don't think lung cancer the first thing, right? So all of these symptoms, if you look at them, are actually not exclusive just to lung cancer. They happen with they happen with the flu, they happen with, you know, just general respiratory infections. So a lot of people don't actually think to go to the doctor, and the doctors don't always think, especially if you're a non-smoking young person, don't think to, you know, take a chest x-ray or to actually do a CAT scan to see if you have lung cancer. Trouble breathing, hoarseness or weakness. And Dan had a couple of those symptoms for sure early on. He had hoarseness or wheezing, and he was tired. But he also had type 2 diabetes. He had high blood pressure. He was taking all sorts of medications for that. And guess what? I read all the side effects of those medications. Guess what they were? Totally. They totally matched them. So it's like, well, and Dan had been telling me he was tired every morning he would say, I'm so tired. And so it was like, how do you know when it's something different? You don't. So that's why the same thing with mammography, we want to go ahead and screen. And actually, I have bookmarks that have this on them, so over on the table, so make sure you pick one up. It's something good to, oh, good, thank you. All right, so now I'm going to talk about lung cancer screening. And if you take anything at all away from this talk, it's this piece right here. Do people have friends and family that are either current or former smokers? Excellent. Okay. Well, not good, but you're going to be able to. I want you to tell them about lung cancer screening because it can save their lives. So this here is a PET scan. Remember I told you about the PET scan where you inject that radioactive glucose? This is what shows up when you do a PET scan. So here's a lesion, there's one, and it's spread. So at this point, if you find it at this point, there's less than 1% 5-year overall survival rate. But if you find it early, there's a 92% 5-year overall survival rate. And this is showing a CAT scan. And here's the little pulmonary nodule. And you found it early, and you get cured. So there's this huge clinical trial called the National Lung Screening Trial, NLST, if you've ever heard those acronyms. Between the years of 2002 and 2004, they enrolled 53,000 people. There were over 33 centers that participated in this clinical trial. The participants were randomized to get either a low-dose CAT scan. The amount of radiation in a low-dose CAT scan is about the same as what's in a mammogram. So this is not the regular CAT scan where it's like 8 to 10 millisieverts. This is less than 1.5. Or a chest X-ray. And they got 3 annual screenings. When they first enrolled, they got a screen, and then after the first year, they got another screen, and then after the second year, they got another screen. So this was only 3 annual screenings. The criteria for who was enrolled was ages 55 to 74. Are they a current smoker or former smoker that quit within the last 15 years? And have they smoked at least a pack of cigarettes a day for 30 plus years? They call them pack years of smoking. So it's a pack a day for 30 years, 2 packs a day for 15 years, any kind of combination there. And I actually found a really cool chart the other day that showed how you could convert different types of tobacco use to pack years, which, so if you know someone who, does snuff or smokes a hookah or any of those things, we can convert them to pack years. Smoking a hookah is equivalent to like 67 packs of cigarettes. It's awful.
It's very popular in college.
Oh, I know it is. It's very scary.
It's nothing bad about it, and they're totally all over college.
Oh. I'll have to send you that slide. Yeah. Yeah, I'll do that.
Send it to me, I'll give it to you.
Okay, good. I'll do that, Nancy. Okay. So this is my favorite chart. And I helped Hartford Hospital implement their lung cancer screening program. And so I helped them put together the presentations where they briefed the docs. And I insisted that they show this chart. And I had extensive speaker notes on how I wanted them to brief it. Most of them ignored it, but one radiologist actually followed my notes. I'm like, yes. So what this is showing is this is the cumulative number of lung cancers that were found with screening versus with chest X-ray, and years since randomization. So remember, they only screened for 3 years. You can see the top line is the low-dose CT scan line, and the bottom line on the top chart is the chest X-ray line. You can see the initial screen, little blip here, second screen, third, and then after that. So you can see how the line, there's a lot more found with the low-dose CT scan. And then you can see how the lines are diverging for a while, then they come back together again after they stop the screening. These are the number of deaths. Once again, you can see that the lines are diverging, but would they have diverged even more if they had continued the annual screening? So the good news is that they're just with this three screens, following them for 7 years, close to 7 years, there was a 20% reduction in mortality with low-dose CAT scans. What would have happened if we would have continued screening? So we have some data that helps tell us what would have happened. Before we stopped screening, while we were still screening, we found that the early stage diagnoses of lung cancer in the low-dose CAT scans group, 67% were found early stage versus 33.2% found late stage. After they stopped screening, in the low-dose CAT scan group, it reverted. 20% were found early stage versus 52.5% found late stage. So that, to me, as an engineer, is proof that if we continue screening, we're actually going to do better than 20%. So this is powerful. So the really, really good news is, when I first started this test was recommended by probably most of the lung and cancer associations and organizations, like the American Cancer Society, the American Lung Association, but it was not recommended by the USPSTF, it was not covered by insurance, and CMS didn't recommend it. Well, through a lot of advocacy and a lot of work, the end of last year, the United States Preventative Task Force came out with a B grade for lung cancer screening. Now, what that means to everybody here is that starting in January of 2015, under the Affordable Care Act, lung cancer screening for the recommended to screen population needs to be covered by insurance without a copay. So just like breast cancer screening is covered without a copay, colonoscopies, et cetera. So it's huge. The people recommended to get screened are ages 55 to 80. Oops. The CMS recommendation is for ages 74. The recommendation from the Medicare folks, you would think that if the United States Preventive Services Task Force came out with a recommendation that would cover the Medicare folks. No, it doesn't. I had no idea about that. Medicare has to do things differently. So they have to have something called a review with a medicine evidentiary committee. So it's called a MedCAC. They had that April 30th. The public could go, so I signed up to go. I have never seen anything like that. That panel had so many conflicts of interest. It was amazing, and they were so biased. So they came out saying that they didn't think CMS should cover it. So now we're in a real political quandary. You know, USPSTF says yes. You know, this committee says no. And you know what it's like when you have an expert committee come in and review it and they don't support what you want to do. You know, how do you get through that politically? Well, there was a lot of work done from an advocacy standpoint, we got almost all of the people in Congress to actually sign a letter that we sent to the Health and Human Services that they needed to cover it. So just recently, on November 10th, CMS came out with their draft recommendation to provide coverage for lung cancer screening. They only provided to age 74 for the Medicare group because they wanted to go with the, do a little political cover, I think, for what the MedCAC folks said. But they're covering it, so we can start from there. And the same smoking history and current or former smoker quit within the last 15 years. So anybody here that has, current or former smokers that meet this criteria, please tell them. And what they should do is they should talk to their primary care physician. Most lung cancer screening is done through a primary care physician referral model. And in fact, in Medicare, they require a shared decision-making meeting with a medical provider. So there's more than 10 million Americans in the recommended population to screen. The reality is that lung cancer screening, the metrics for the number you need to screen to prevent a death and the cost to prevent a death and all of those metrics are better than for mammography, better than for colonoscopies, and better than for PSA. So it's a very effective targeting screening for a population that's at risk that dies. It's estimated to save more than 20,000 lives a year. That 20,000 lives a year is predicated on the 20% mortality rate. We've already talked about how that's probably underestimated. And then an additional benefit, and we're going to talk smoking here in a second, is that it's actually effective from a smoking cessation standpoint. The published smoking cessation rates, and there's been quite a few lung cancer screening trials, they're a lot smaller than the NLST, but it shows that there's about 2 to 3 times the smoking cessation rate in lung cancer screening trials as there are in the general public. So general public, it's about a 6% every year people quit successfully. In lung cancer screening trials, it's more like anywhere from 11 to 24%. Now, these are trials. What's going to happen when you're in actual real life, clinical practice, as they would say? Because in clinical trials, there's a bias that's often called the healthy volunteer effect. Hey, is it only people who are worried and are going to quit smoking anyway that volunteer to get screened? Well, at Leahy Hospital Medical Center, that's not a clinical trial. That's in practice. They're doing it. And I was able to, we're going to publish the results, but their smoking cessation rates in their lung cancer screening program are 18%. So that's really encouraging that it's not just in the trials, but it's also in actual clinical practice. So we get a twofer on this from public health. We reduce deaths from lung cancer, and we get people to stop smoking, which, as you'll see, is going to reduce overall mortality because there's a lot of other things that smoking drives. And I love this quote. This is the biggest impact on lung cancer we have ever seen in our lifetime. This is huge. This will do more to save lives than anything else we have done to date in lung cancer from a clinical perspective. So it's huge. Now we really need to spread the word and let people know about it. Go ahead.
So somebody would start at 55 3 times a year for forever.
Once a year. It's an annual screen.
Once a year.
Until they reach 74, or if they have private insurance, they can go to 80. That's probably going to be tweaked as we get data in. But right now it would be, let's say they're on Medicare, it would be 55 to 74.
So it's a once-a-year screening.
Yeah.
Prostate or
Yeah, mammogram, you go in, colonoscopy is once every 5 years, but it's like a mammogram, most women I think go every year and they just do it. I mean, the one thing you have to be aware of is there is a false positive rate like there is for any screening. For the most recent guidelines, it's going to be in the order of 10 to 15%. Most of the false positive, what happens is you have to go back and get another CAT scan within 3 months, or within 6 months, depending on what you see. In a small percentage of cases, less than 2% of cases for false positives, you'll have they'll go in and you'll have something that's called an invasive procedure, either a biopsy or something, and but that doesn't happen very often. But this is huge. How many of you have heard of lung cancer screening? I know you have, Pat. Okay. All right, one of the big things that happens with smoking is there's a really strong stigma because of the link with lung cancers because of the link to smoking. This is side by side showing a Google image, a search on Google Images on breast cancer people, and on the right is lung cancer people. It's incredible. On the left is all pink, happy people. Now, I'll tell you, breast cancer doesn't look like that, but that's what the image is. On the right is what happens with lung cancer people. All they show is smoking, awful images, etc. So, and people with lung cancer either are blamed or blame themselves for their disease. Even people who've never smoked and get lung cancer experience the stigma. It's a big issue. I know my husband said, Andrea, I did this to myself. I know his sister said the same thing. It broke my heart. We'll talk about who to blame here. in a minute. How many of you have seen the CDC Tips campaign where they show you all the horrible things that happen when you smoke? So that just makes it look awful. We as humans have evolved to, when we see disease, to recoil from it as a protective mechanism, because in infectious disease, if you get close to someone who's sick, you're going to get it, and so the same thing happens when we see something that might not be infectious. So basically, the lack of survivors and the stigma that's associated with this has resulted in very little dollars for research. You can see breast cancer, 26,000 per breast cancer death. Lung cancer is down about 1,400. So the stigma has been a huge issue. So this is who we're going to blame, okay? Big tobacco. We think they're not targeting or marketing. They're marketing all the time. Every adult who dies is replaced by 2 new young smokers. 1 in 5 adults and teenagers smoke. 8.4 billion is spent on advertising every year, 23 million every day. And this was something that really amazed me, is that 90% of regular smokers start before the age of 18. Smoking is harder to quit than heroin, because it's not only addictive, but it's a constant addiction. It's the whole social behavioral interaction as well. So it's just, now, the good news is there's good ways now to quit smoking. It's not like in the old days when we had to do a cold turkey. There's very effective interventions. But we shouldn't be blaming smokers. We should be blaming the tobacco companies. We've shown that the adolescent brain doesn't mature until they're in their 20s. They can't make judgment decisions with all the marketing. So that's who we blame. Okay, so smoking causes not only lung cancer. It causes 13 other different kinds of cancer. This is not an association, not a risk factor. It's been proved that smoking causes it. So lung, kidney, pancreas, colon, bladder, liver, and the list goes on.
Now, when they do that screening, it's only for the lungs to pick it up.
Right, but you do see, because, and that's, thank you very much for, I should have addressed that. You do see other things when you do that CT scan. So you actually can pick up what they call incidental. So they pick up things in the thyroid, they pick up coronary diseases. So if we take a look at the overall reduction in mortality, you're probably going to pick up more stuff when you do this screening. Oh yeah, 1 in 3 cancer deaths are tobacco related. That's huge, guys. So that's not only lung cancer. Do you all know what COPD is? Emphysema and chronic bronchitis. It's basically also caused by tobacco. And where you get to is that you can't get the breath out of your body. Results in very poor quality of life, breathlessness, not being able to breathe. It's horrible. That also is caused by smoking. And COPD is one of the big risk factors for getting lung cancer. Both my husband had COPD and my mom had COPD due to smoking. And from the standpoint of cardiovascular disease, okay, so we talked about 160,000 deaths from lung cancer. Well, guess what? Cardiovascular disease is the #1 cause of deaths in the United States. There are more people who die from smoking-related cardiovascular disease than from lung cancer. So smoking is a huge deal from that standpoint as well. And it really it damages the blood vessels, and we get clots, and away we go. It makes all types of cardiovascular disease worse. Okay, so what about the government policies around smoking and big tobacco? After the Surgeon General report came out in 1964 that told us that lung cancer was caused by smoking, we had to have warning labels on cigarette packets. In the 80s, we got a ban on cigarette and smokeless tobacco advertising on TV and radio. We started restricting smoking in public places, increasing cigarette taxes. Increasing cigarette taxes has been very effective. They found that for every 10% increase, you reduce consumption by 3 to 5%. Because once again, remember, we're targeting those young folks. The reality is, if you take a look at the prevalence of smoking, we've gone down from, we've definitely reduced the amount of people that smoke, but the total number of people that smoke is the same. There's still 40 to 50 billion smokers in the United States that smoke every year. Agreed. There was a tobacco master settlement agreement in 1999 that said $205 billion that have to be given by the tobacco companies to, and there's 46 different states that settled with them. It's a big settlement with the Attorney General over what the tobacco companies did to induce people to smoke. And tobacco companies are very smart. You know where that money goes? It goes into the general fund. Do you know how much of it is spent on tobacco control and smoking cessation? Very little, and I'm going to show you here in a minute. So lung cancer incidence has been reduced from 42% to 18%, so that's a good thing, and that's because we did decline in smoking. But the Surgeon General report that came out this year said we still have 5.6 million youths that are going to die prematurely because of tobacco-related illness. And the big new threat that we need to be aware of is e-cigarettes. E-cigarette use in youth has doubled from 2011 to 2013. It doubled from like 3 to 6%, but it's a huge deal. There are no limits on e-cigarette marketing. Every morning when my radio comes on, my radio alarm, guess what? Vape Shop up in Enfield is advertising. So it's very, very... It's something that I would say is going to be our next public health emergency if we don't address it. It's basically an electronic cigarette, so they put, thank you for that question, they put liquid in a tube. They say it's vapor, but there's additives in it, and they put flavors in it, and basically it's non-combustible nicotine delivery system is what I would call it. There's still nicotine in there. So there's nicotine in there and there's other things in there. And we don't know the long-term effects of e-cigarettes. And one of the things that's happening is it's becoming a gateway to teens starting with e-cigarettes and then transitioning to regular cigarettes. They've done a lot of surveys where they've said, where teens have said if they actually use e-cigarettes, 50% of them say they're going to start smoking regular cigarettes. And the tobacco companies are advertising. They're using exactly the same ads that they used to use, you know, selling it with sex and coolness and all the rest of this stuff. If you look at them side by side, there's a great Stanford website that shows side by side the old cigarette ads and the new one and the e-cigarette ones. They're almost identical. Same concepts, same color schemes in some cases. It's amazing.
So isn't there a misperception though? Yeah, I hear people who are smokers saying, I'm quitting smoking and I'm starting with the e-cigarette.
Right. There's a big debate right now in the public health community saying, hey, we can save a lot of lives if we can transition people from cigarettes to e-cigarettes. I was walking down the street in Brooklyn with my 12-year-old niece, 12-year-old nephew, and a 10-year-old friend of theirs. And we walked by a vaping shop. They call them vaping shops. We walked by a vaping shop, and they started talking about, oh, you know, it smells so good. It's just vapor. It's not that bad for you. So the message, that's what they're hearing. That's what they're getting. So we need to do something about this. Okay, and the reality is, you know, the FDA now regulates tobacco. They didn't used to in the old days, because the FDA's charter is that they can't make something legal if regular use results in sickness and death. But they gave them an exception for tobacco. We have such large tax revenues and lobbying that we don't have the will to make tobacco illegal. Okay, this just shows the grades we get for, remember I told you about the Master Settlement Agreement money? Connecticut got an F in spending on tobacco prevention and programs to help prevent smoking, and they got an F in spending on and tobacco cessation programs. They got an A in excise taxes, so they're really good at making money, right? You would guess that. And a C in smoke-free laws. Yeah. Okay, so in summary, lung cancer is a non-infectious chronic disease. More than 80% are caused by tobacco use. We talked about how our youth, 90% of regular smokers start by the age of 18. Harder to quit than heroin, and it's more addictive now than it was in the 1960s. Lung cancer is the most common cancer and the leading cause of cancer deaths. The mortality rates are high because we don't diagnose it until it's spread. Both the United States Preventive Services Task Force and CMS now recommend low-dose CAT scan screening annually for the high-risk population. And if you take anything away from my talk, please tell people about that. I have brochures. That is like the most important message. We can prevent deaths. That and don't smoke. And then tobacco control efforts, although there are some successes, I think they've pretty much failed. And e-cigarettes threaten to erode what we've done from the standpoint of denormalizing tobacco. And we need to increase research funding for improved screening and treatment modalities. So I have.
Cigars and marijuana.
Okay, so totally agree. I'll give you.
You
Yeah.
had a thing that converted
Yes, I don't. Yeah.
marijuana, e-cigarette.
It doesn't have marijuana on there because marijuana is not legal yet. I can't believe that we would ever consider legalizing marijuana. There have been no links that I've seen between marijuana use and lung cancer, but there's conflict between some of the studies. I would think that there is no way we would ever legalize marijuana from that standpoint.
But it's smoking, it's carcinogen, it's the same thing as cigarettes. And
Well, it
there's
has
debates
different.
whether it's worse or better or
Yeah, there's a lot of debates about that.
cigars. I read something the other day about
Yeah.
cigars that most people think that's not.
No,
And
they're,
obviously
cigars are actually, if you take the little ones, I think they're actually worse. I have to go back and look at that table again. I just saw it actually,
Right.
the first time I've ever seen any conversion anywhere was just a couple of days ago,
Okay.
which I was glad. But cigars are, all tobacco products are bad for you. Yeah. Well, I don't think that's actually true. What? Where? Oh, okay. No. Oh, okay. That just says that people are quitting. Okay, I see where that can be confusing. Sorry about that. Here, this slide? Yeah. Okay. All that says is that a lot of people are quitting, but even though they're quitting, they're still at risk of getting lung cancer. What they found is that once you've done the damage, you don't reverse the damage by quitting smoking. It stays there. You just don't increase it. So for example, in my husband's case, he was a heavy smoker. He started smoking back. He was 17 years older than me, so he started back smoking before the Surgeon General reports came out. And although he quit 11 years previous, which is quite a long time, he had caused so much damage. The damage doesn't go away, just doesn't accumulate. So as far as less than 40% currently smoke, that just means they haven't quit smoking. You should take a look at this and think about this as these are the people who have damage due to smoking.
90% of people who smoke.
I would say it's more like 85%. This is 15. So 85% of the people who are diagnosed with lung cancer have done damage either by through smoking. And just because they quit doesn't mean they've reduced the risk. A lot of misconception that I see is they have those commercials on TV where they tell you about how if you quit smoking, your risk of cardiovascular disease in 10 minutes, your heart rate comes down in 6 months, and that's true for cardiovascular disease, but people think that the same thing is true for lung cancer, and it's not.
Well, if you were, say, 12, 18
Yeah.
Given the young person that they are, and they're still growing, sure.
Yeah, there's probably not an issue there. At this point, what they call ever smoker is 100 cigarettes or more in your lifetime. They say you've smoked. So, but typically what they're saying here is if you have less than a 30-pack year history, so let's say you smoked a pack a day for 3 years, you know, that's a 3-pack year history. So that doesn't come anywhere close to the 30-pack year. It's really an cumulative damage.
Do you know why people who've never smoked get it? I mean, is it secondhand, or is it?
It's all of those. It's radon, as we talked about. So radon is the second leading cause. Air pollution, occupational exposure to carcinogens like asbestos, silica, coal dust, diesel fumes. There's a cadmium. There's a whole list of those as well. Arsenic. So, and we don't know all the causes, but those are some of the common ones. Those are the things that we look to and screen for.
And then somebody had an advanced question.
Yeah. Okay, let me read this question. I do not smoke, however, a few times a year, maybe 6 to 8, visit Mohegan Sun Casino. Even though there's a non-smoking section, you need to walk through the smoking section. What's the risk with secondhand smoke? I can feel it in my chest by the time I leave there. We do know that secondhand smoke does cause lung cancer, but right now they don't have clear consensus on sort of the dose-response relationship, so it is not recommended that people who have secondhand smoke exposure get screened. I would say if it's it's never good, but if it's occasional, it hasn't risen to the same level of risk as having been exposed to radon or asbestos, et cetera. So, you know, maybe try and hold your breath as you walk through there.
If you're fortunate and you catch it early and you have the surgery, say,
Mm-hmm.
there's still some probability that it's going to recur?
Totally.
Is that kind of in that 10%, that with the 90% chance of 5 years survival, but there's really some chance that something, eventually there's only so much longer you can remove. If you found that it
Right. Okay, so yeah, reoccurrence, and there's not clear consensus on reoccurrence rates as far as how many people reoccur. Some say, because it's so dependent on what you find in your own personal situation. But what they're looking for now is they're looking for markers in your tumor. Let's say they found a small tumor, they did a wedgectomy, took that out, and then you have the option of deciding along with your medical team whether you want to do chemotherapy or radiation just to, you know, try and get rid of anything that might be left that you can't see, that's, you know, microscopic. And what they're looking at now is they're doing studies where they take a look at the characteristics of your tumor to see which ones are more likely to reoccur. And then if you fit in that category of, hey, this is more likely to reoccur, then you can get that systematic therapy. Because chemotherapy destroys things other than the cancer, and so does radiation. So it's not sort of like, okay, absolutely everybody should do it. But there is a chance of reoccurrence.
All right, we have time for one more question. And then what we're going to do is excuse everyone, and then if you have more questions after that, you can stay afterwards, and Andrea will talk with you. Go ahead.
Oh, the radiation, it has to be less than 1.5 sieverts, millisieverts. And in fact, a lot of them are getting less than 1 millisievert, and I've seen some numbers at, you know, 0.7 to 0.8 millisieverts. So there's the risk of radiation just to having a low-dose CAT scan. But if we take a look at the population we're talking about, we're not talking about young children, we're talking about age 55 and up. So even if you screen for the full, you know, 15 or 16 years, the risk of getting lung cancer from your smoking history is a lot greater than, you know, getting it from being scanned.
So thank you, Andrea, for coming in today. Let's have a nice one.
Thanks for having me. I appreciate it.